All right, I think we're all set. So first, I want to thank you for coming. My name is Lata Rajan. My co-chair is Gillian Richardson. So welcome to this very relevant symposium. Just a very quick introduction. Gillian works for the Louisiana Office of Public Health in the Infectious Disease Epidemiology Department, and I am a professor of tropical medicine at Tulane University in New Orleans. So both of us based in New Orleans. So there's been a few changes in the program, and I circulated the changed program. We unfortunately don't have some of the speakers that were supposed to come. For example, Sahar Zalou, he works with the Syrian American Medical Society, right? And we were looking forward to his presentation, but there was a problem, he couldn't come. But Dr. Aula Abara, who will be doing the first presentation today, works with him, and she has his slides. She's also included some of his content, so she will do her presentation. At the end, she will use present some of his slides. So we got it covered there. The other person is Akram El Tom. He works in Jordan. He couldn't get a visa, and as we heard for several speakers in this conference, the visa problem you must have heard already, right? UK has really tightened its borders, so that's become a really big problem. Anyway, so the second presentation we'll have today is a joint presentation from two speakers from the International Organization for Migration, IOM, Alexander Galev and Saiful, wait, let me make sure I get his name correct, Khayyam, right? Saiful Khayyam, right. So Alexander isn't feeling well this morning. He may or may not come, but then Saiful will cover the whole presentation if he doesn't. So we may end up with Aula doing two presentations in the beginning and Saiful doing two, so just two big presentations. As far as format, once Dr. Abara finishes, we'll ask if anybody has one or two pressing questions, we'll take it then. If not, we'll just hold questions to the very end. We're hoping to get about 20-25 minutes for discussion at the end. We're trying to leave a lot of room for discussion because I'm sure you guys are very interested in this topic, and I think it'll be very interactive. So that's the format, right? With that, let me introduce Dr. Aula Abara. My notes are here, okay. So she is a clinician, an MD, well, not in the UK, they don't call it MD, so I'm so used to saying MD. She's an infectious disease clinician. She's training, doing her fellowship, but more relevant to what we're going to hear today is her work with the Syrian American Medical Society. She's the clinical lead for the global response in Greece, right? And I will let her tell you a little bit about the society before you start with your presentation. Paula?
Lovely, thank you. Is it possible for me to go around? Should I go around there?
I'll do it. You can. You want to?
It might be easier actually.
You want to do it this way?
Yes.
No problem at all.
I can combine the slides as well. Lovely. So good morning, everyone, and welcome to today's symposium. I think the first thing to do is to commend Dr. Latha for organising today with all the hiccups that have been happening in the last few days, and I hope that you will all find today's presentations and discussion useful. So the Syrian American Medical Society is rather a mouthful, so for now I'm going to call it SAMS. So SAMS is an American-based foundation which has been present in the US for Syrian physicians who are working there, but also those of Syrian heritage in the US. And of course, after the conflict, it became much more prominent as a charity, as an NGO, and as a provider of medical care both inside Syria, but also in the countries receiving refugees surrounding Syria. Excitingly, at the start of this year, we formed a committee for the SAMS Global Response, And the idea behind that is, with the expertise that we've garnered inside Syria, working amongst the toughest humanitarian conditions known in the current in the current state, perhaps we can help in other countries who may benefit from this expertise and what we've learnt. So our first project since mid-April has been to provide primary healthcare services in northern Greece, and we're also exploring other avenues. So what I'm going to be speaking about today is tuberculosis amongst Syrians from a physician's perspective. I'm going to start by saying that I've got no conflict of interest. What I will cover today is what we know about Syria's health system pre and post-conflict, and what we know about tuberculosis in Syria both before and after the conflict. I can never tell whether it's easier to try and present something where little data is known or where a hell of a lot of data is known. I have to say this is more for the former, and you can assess how well you can find out about tuberculosis in Syria with what we do know. I'm going to make special note of the prison population because actually that's the ticking time bomb not only for TB but for drug-resistant TB. And then I'm going to say a few words about what the way forward could be, because actually that's the crux of the matter, and I think that's why we're all here at this conference. So what was Syria's health system like before the conflict? It was a mix of both government-run hospitals and primary care facilities. The Syrian Ministry of Health was mandated to provide care for all its citizens. There was advanced medical care in the major cities, including Damascus and Aleppo, but in rural areas there was insufficient healthcare, insufficient training and human resources, and actually those are the areas where there was the greatest need. Some say that it was actually the drought in those rural areas that was one of the drivers for the protests and then the conflict which we now see before us. So the Syrian Ministry of Health was the main provider, but there was an increase in private sector actors. And in many areas, particularly in Aleppo and Damascus, there was an increase in public-private partnerships. Importantly for Syria, and now for the Syrian refugee crisis, there is a drift from communicable diseases to non-communicable diseases. So if we compare Syrian refugees to refugees from other parts of the world, so if we think about Africa, it's actually NCDs that are much more of a problem, though of course we're here to talk about TB, and of course communicable diseases are important. Vaccination rates in Syria were high, so the estimates were that they were above 90%, and this fell to about 50% a couple of years into the conflict. And so we've seen everything from measles, hepatitis A, to typhoid, and the potential increase in tuberculosis. It's important when you see Syrian refugees that those over the age of about 6, they probably would have had a BCG vaccination. Of course, that has an impact when you interpret their TSTs. And sadly, all of that has changed after the conflict. So what we have now is a decimated health system in every possible way. Valerie Amos always says that whenever she presents statistics about Syria, they're always out of date. These are about 6 months old, and I can tell you they're out of date because this last month has been particularly bad for the bombings of hospitals, particularly in Aleppo. So now more than 60% of hospitals have been destroyed or severely damaged. More than 800 healthcare workers have been killed, many of them deliberately targeted, many of them arrested. And very early on in the conflict, the government made it illegal for a physician to treat someone who is fighting against the government. And so just by providing medical care, even if you're a physician and wanted to be impartial, you could be arrested for the crime of providing medical care. Before the conflict, Syria had a very good pharmaceutical industry, particularly around Aleppo, and it could produce more than 90% of the medications needed. The conflict has resulted in a 70% fall in pharmaceutical production, and that has been catastrophic, both in economic terms and also for the availability of drugs, particularly now that to travel from one area to another, you'll have to go through several checkpoints and you may not make it through. The infrastructure has been destroyed, so fuel and electricity shortages are rife, and many hospitals now, especially in the non-government controlled areas, run on generators. And there are certain groups which have gravitated towards the oil fields, and they charge extortionate prices for fuel to run those generators. And again, that has been catastrophic, and again, that has been harmful to Syrian civilians. And the breakdown of sanitation has been rife, and that includes garbage collection, inadequate water, inadequate sewage, and that has seen a rise in all sorts of communicable diseases, including very much so cutaneous leishmaniasis, which had been under control prior to the conflict. So what does this all mean? I think it was 2014 where the UN stopped counting the civilian toll. So the figure currently bandied about is at least 500,000 killed. To me it seems very arbitrary, because that's the same figure that's been there for 6 months. And we know that there's been a lot of deaths, and I think many of you will know that yesterday there was a bombing in Idlib where school children were killed, so the death toll climbs each day. At least 850,000 have been severely injured. I think the figure's more like 1 million, and these are injuries with significant amputations and paralysis and all sorts of war-related injuries. More than 80% of the population are living in poverty, and life expectancy has fallen by 20 years. So it was 77 before the conflict, and it's now 57. Part of that is because of the number of children and infants that have been killed, but also young men and young women are dying in the conflict. And I've discussed the rise of communicable diseases, and I will go on, of course, to speak more about TB and drug-resistant TB today. It is important to remember, for those of us who are general physicians, when we see Syrian refugees, to take into account the non-communicable diseases, because they are a great burden and they are a source of mortality, and actually they're much harder for countries such as Jordan and Lebanon to manage. The particular cases of oncology, which is very expensive with no certainty of cure, and the particular case is actually paediatric oncology. Other cases to take into account include diabetes, hypertension, and other cardiovascular risk factors, which are also significantly contributing to morbidity and mortality. Inside Syria, there is limited access to healthcare, and I think you can see the reasons why. And of course, the strain on neighbouring countries is huge. So what do we know about tuberculosis in Syria before the conflict? And the answer is not very much. There was a national TB programme, and I found a very interesting report, which I'll give you some of the details from 2007, where they had a 5-year strategy to reduce rates of TB and increase case detection. The programme was in conjunction with the UNDP with funding from the Global Fund. So what you'll see here is a map of Syria, and I was just going to show you that in Syria there were 14 governorates. And it's these governorates up here, like Raqqa, Hataka, Deir ez-Zor, and some areas around Latakia, which is one of the coastal towns, and Idlib, where there is very high rates of poverty. And it was estimated that at least 35% of people living in those areas, many of them were very rural, where TB was much more of a problem, and access to healthcare, particularly in those areas, was of a greater problem. So in this document, the TB strategy from 2007 to 2012 had 3 main parts. The first, and perhaps the most important, was to improve detection, and that's by improving surveillance, but also addressing low case detection rates. So they estimated that only 46% of patients with TB were diagnosed and treated. And the interesting point that they make here is one that we're lucky in that we don't face in the UK, where the majority of TB will be treated in our National Health Service. But in Syria, they found that there was a lot of private providers, and what that meant is they would not benefit from the government's DOTS programme, and it was much less regulated, so there might be more treatment interruption, there might be more non-standard regimens being used. The plan was also to build capacity of diagnostic laboratories, not just the reference laboratories, but also, I think they said that they wanted to have 65 laboratories across the country which could diagnose and perhaps do simple cultures for TB. And they also wanted to address management, and in particular, it's with regards to multi-drug resistant TB, where the estimate at that time was 4.4%, and a quarter of those patients had been previously treated for TB. They wanted to improve DOTS coverage, and the plan was perhaps one of the doses will be witnessed by a health professional and the remaining doses taken by the patient will be witnessed by a trusted family member. And importantly, and I think that's very important for people that come to the union conference, they wanted to improve access and advocacy. And that was particularly to vulnerable populations, so those in the very rural areas, perhaps with poorer access to healthcare, poorer educational attainment. And they also wanted to strengthen the health system in Syria. And part of that was about advocacy, education, communication, and social mobilisation. I wouldn't underestimate how stigmatising telling a Syrian patient that they have TB is, in the same way that when I meet many of my Indian patients in London and tell them they have TB, particularly if they're from the middle class, they'll say, no, 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 only poor people get TB. And it's very much the same attitude when you speak to Syrian patients. So it is alarming for them even to be told, for instance, that they have latent TB, and they won't always understand the distinction. And so it's hard to gauge the accuracy of TB rates before and even after the conflict. The estimates I've seen for 1990 are anything between 60 and 85 per 100,000. And I know I don't need to say this to people in the room, but just to put it into context, the WHO say anything above 40 per 100,000 is high prevalence. And I work in northwest London, where at the one hospital that I work in, we see about 300 patients with TB. And the area that we work in has a TB prevalence of up to 99 per 100,000. We're not the highest prevalence in London. There's another borough where the TB prevalence there is 108 per 100,000. If you'll believe the figures, in 2011, TB rates had fallen to 23 per 100,000, and it would suggest that, okay, perhaps there were a lot of undiagnosed cases, but also they were going some way to controlling TB. And I was going to make some note about Syria's health system, because I've been talking about Syria as though it's one entity, and very sadly we know that there's at least 3 or 4 almost separate governments at play in the country at the moment. So I'm on the steering committee of something called the Syria Public Health Network. And what that is a collaboration between NGOs, academics, government actors, DFID and others. And we have closed meeting every 3 or 4 months to discuss specific health topics relating to Syria. So we've had one on mental health. Our very most recent one was on non-communicable diseases, and we're now partnered with the Chatham House because part of this is about advocating what the priorities are, and particularly what the research priorities are for governments to address. And we had a session on health systems, and this, even for me, was an eye-opener. This was at the beginning of this year. And the way it was described is there's more than one health system functioning in the country, so we can no longer talk about Syria as though it's one entity. There are government-controlled areas and non-government-controlled areas. The importance of this distinction, and I'm happy to be corrected, but international bodies like the WHO, the World Food Programme, UN organisations, even some of the international NGOs are mandated to work with the sovereign state. So that makes everything from delivering vaccines, because obviously that will go through the Ministry of Health and is more likely to go to the government areas. There may be some crossover into the non-government controlled areas. And that really does leave the non-government controlled areas without adequate health care. I suspect that the National TB Programme in government controlled areas is still functioning in some form, but I can tell you 100% that that is not the case in the non-government controlled areas. And that's where Syrian NGOs such as SAMS are very, very important, and there are many others and many other collaborations that are working to provide healthcare in those areas. So who's providing care in the non-government controlled areas? Well, it's the various opposition forces, the so-called Islamic State, who I think when I say we don't know what's going on in Syria in general, I can say full well we absolutely do not know what's going on in areas such as Raqqa, who are under complete control of the so-called Islamic State. I put here Daesh because it's important to know this is the derogatory Arabic word by which they are known in Syria, and as you can see, they are deeply unpopular. There are also semi-autonomous Kurdish areas, and again they have a different way of managing the healthcare in those areas. And I think it's safe to say when discussing the health system in Syria that it is fragmented, uncoordinated, and it's increasingly militarised and politicised, which is not something that we want for any of our patients. So what do we know about Syria post-conflict? Well, we just don't know the burden, and that's a particular concern in the prison population. We know that prisons internationally are where TB is greatest, and that's certainly the case inside Syria, and I'll speak more about that in a later slide. The health infrastructure is destroyed, and what that has meant is there's been an exodus of health staff and specialists. So Syrian physicians in the past, and probably still currently, had a good reputation. Patients would come from other parts of the Middle East, particularly to see the surgeons, dentists and physicians. What we have now is few functioning facilities. There's a lack of availability of anti-tuberculous drugs. So to give you an anecdote, a couple of years ago, someone from the Aleppo Medical Council contacted me and said, look, we have 27 patients who were on TB treatment and now their treatment is interrupted. Can you help us? And I put out feelers amongst my contacts, and I won't go into details, but the final contact was the EMRO representative to the WHO, and he very rightly said, look, this has to be through the National TB Programme. Give me a list of those names and I will send it to the NTP, at which point I said very politely, thank you very much, and the conversation closed. Because it's not safe for me to give the names of patients potentially in non-government controlled areas to even those with the Ministry of Health, because I can't put those patients at risk. It does mean that I don't know what happened to those patients, and of course it's very difficult to access anti-TB drugs quite rightly outside of established systems. There's also now displacement with overcrowding, and of course overcrowding is a fantastic way to spread TB, particularly if there's poor ventilation, particularly if, because of the concern about barrel bombs and missiles, everyone moves down into the basement where ventilation is even worse than in the upper parts of the building. And there's further strain on water and sanitation. Importantly, the issue of access and checkpoints and those under siege needs to be explored, particularly with relation to TB. So this little diagram here is of Aleppo at the end of last month. So the areas in, I think it's kind of a greenish blue, are those under opposition control. The little yellow area here is under Kurdish control, and you can see the government-controlled areas surround the whole of the city. And I think you know that it was under siege for much of, I want to say, August and September, when Castello Road here, which is the main thoroughfare, was blocked off. Zahir Sahlul was actually in Aleppo just before Castello Road was blocked. What that means is if you're a patient here and there's no access to healthcare and there's probably no access to TB treatment, it's going to be very difficult for you to get through any checkpoints, especially if you're a young man, because you will be treated with suspicion even if you have not done anything to warrant it. And so diagnosing TB inside Syria is a challenge, and it's a particular challenge in the government-controlled areas. So I'm also the project lead for SAM's Infectious Diseases project, and that's actually about normal bacteria and antimicrobial stewardship, infection prevention and control, and building capacity of microbiology laboratories. At the start of this year, I was in Gaziantep in the east of Turkey, where I did a gap analysis focusing on what the needs were of the different microbiology facilities, and I met with representatives from Idlib, Hama and Aleppo. So what SAMS does is every 3 or 4 months we run training courses in Gaziantep, which is very near the Syrian border. So healthcare workers come out and they have training in ALS, APLS. I do the infectious diseases lecture. There's paediatric. We've started a family medicine. Sorry, am I right for time? Started a family medicine course as well, and then they go back into Syria, and that's the way that we can try and help those health workers develop. And at that time, from the 4 or 5 microbiology technicians, pathologists, and those who were running the laboratories, I knew that there were few functioning laboratories even just for simple microbiology, so simple gram stains, let alone anything more complicated. They always bring up the issue of TB, and I did explore it, and they do like technology, and they were asking me about machines to diagnose TB. I expect they meant CEFID, and of course this is not a situation where we can put a gene expert or a CEFID machine in. one or two of the laboratory technicians I was speaking to could do the Zeal-Nielsen stain, and actually that would be the only way that they could diagnose TB. And of course we know that smear-positive TB doesn't account for all pulmonary TB cases. And of course none in these non-government controlled areas would have the ability to do TB culture or sensitivities. And in fact, even blood cultures, I think there's one lab just between the Turkish and Syrian border where they can do blood cultures. So this is one of the wonderful microbiology technicians who was originally from Halab, who sent me this photo, and he was very proud. This was back in June, and it's one of my favourite and treasured photos, and those of you know what happened to M10 will know exactly why that is the case. And you can see how wonderfully he set everything out. And I just wanted to show you a theatre in eastern Aleppo. This is one of the largest functioning hospitals. They had about 40 beds. I met some of the doctors there, and I'm quite fussy even for my patients in London about which consults you'd want for them. And certainly the doctors that I met there were people I would love to have see my patients. To give you an example, when I speak to them about some rewrote antibiotic protocols, and actually they were quizzing me about up to date, and they were saying, well, up to date doesn't say that, and the IDSA doesn't say that. And so those are the calibre of doctors that were working there. And this is M10 at the end of last month. And that is one of the major challenges that we would need to address if we are to even diagnose TB, let alone think about managing it, and let alone think about managing drug-resistant TB. So what does all this mean? Well, there's an inability to diagnose TB except possibly by smear. There's an inability to treat on suspicion. So remember, Syrian physicians wouldn't have seen that much TB. So down in London, my differential is usually TB for anyone that comes in with a fever and a cough. Whereas in Syria, it's more likely to be something else. And actually, most of the physicians have left, and many of those who stayed are medical students or very junior, or even some examples of vets now having to treat humans. And there's also a lack of medication, so even if you do treat TB, what are you going to give them? If you're in a non-government controlled area, you're not really going to be able to access the NTP very comfortably. There's also a frank inability to do any sort of follow-up or assessment of compliance. Some of the major work I do is relating to bone infections and amputation infections. So even for those patients that don't need as close follow-up as TB patients would, there is interrupted treatment, and there's an inability to really be able to provide adequate follow-up, let alone for TB, where you have to ensure that they're actually taking their treatment. And I think in this situation I would say that DOT is out of the question unless you had a family member doing it. What could be possible, and actually SAMS have been at the forefront of this, are things like telemedicine. So they have a very good telemedicine ICU programme. At the moment, it used to be that they were supporting 10 ICUs. I think that's fallen to about 7 because they keep getting bombed. And actually things like video observed therapy, which I know there's been trials of in London that we were part of, and also elsewhere in Africa, might be an innovative way to ensure that patients are taking their TB treatment, and perhaps that's something that can be considered in the future. It also means that there's overcrowding and displacement, and that's a surefire way to increase transmission. And to be honest, I just don't think we know what the real burden of TB is. Having said all of that, this is the WHO data from 2015. And you can see at the bottom here, it says the estimates of TB and MDR TB are produced by the WHO in consultation with the Ministry of Health in those countries. And what this is reported as in 2015 is an incidence of 3.6, and that's in thousands, with just under 3,000 cases reported, and just under 80% of the pulmonary patients are bacteriologically confirmed. I don't know how to interpret this data because I don't personally think it covers the non-government controlled areas, but if there are people from the WHO here who might know more, I'm happy to be corrected. And then as far as TB treatment coverage is estimated at 80%. So this graph is taken from some work I did with some colleagues earlier this year. And what we did was look at the early warning and response system, which is the WHO-led EWAR system, where they have a number of sentinel sites, probably mostly in the government-controlled areas, from which they report certain diseases, so respiratory tract infections, cases of hepatitis, gastroenteritis, bloody diarrhoea, and amongst others. And in blue we have the ACU EWARN system, so Early Warning and Response Network. The ACU is the Assistance Coordination Unit, which works with the Syrian National Coalition, so I would assume that most of the sentinel sites that they follow are in the non-government controlled areas, but I never know that things are that clear-cut, and also it's a very fluid situation. What you can see here in the kind of red line is just how many cases of TB are being reported, versus in the blue line, just how many cases here are being reported. I think this is multifactorial, and I would say some of it is related to the fact that for the WHO EWAR system, confirmed cases are in line with the NTP case definition, so they may not ask for bacteriologically confirmed cases. So someone with a cough for greater than 3 months, or someone with symptoms suggestive of TB, might be flagged up on the EWAR system. Whereas for the EWARN system, they say that only information on confirmed TB cases is gathered, and actually it's under the category of other. And perhaps one thing that perhaps the union could advocate for is for someone like the WHO and those who are looking at the core surveillance list to insist that TB should be on that, particularly if we think there's an explosion of TB going forward. So I'm going to speak a little bit about the prison population, because I really think this is where we're going to see the highest number of cases. There have been a number of reports from Amnesty International and Human Rights Watch, and I'm not going to apologise for the fact that I couldn't read them all. I still have family members in government-controlled prisons, so it's still very sensitising. But it's needless to say that healthcare is inadequate or non-existent, disease is rife, torture is rife, and overcrowding is rife. I think one statistic I saw was that in a cell of 6 by 5 metres, there are 100 people, and they sleep in shifts. And sometimes if someone dies, they won't necessarily be removed straight away. So I've just been told to go a little bit faster, so I will do so. We don't know how many people are imprisoned. It's estimated there have been more than 500,000 arrests. I expect there's tens of thousands in prison, and we will never know the true number because there are multiple disappearances almost every day, even now. And that was the case before the conflict, but now it's grown exponentially. There's an estimate of between 18 and 60,000 deaths, and the estimates from different bodies. The 60,000 deaths is from the Syrian Observatory for Human Rights. And you can see why these patients in prison are going to represent a burden of disease. There's overcrowding, there's malnutrition. One statistic I saw was that each person would get a loaf of bread for a 30-day period. So on average they're losing 10-15 kilos. And of course micronutrient deficiency and everything else that will weaken the immune system, weaken the cell-mediated response, and allow for any disease, not just TB, but gastroenteritis amongst others, to take a hold. There's poor ventilation and there's no health care in these areas. One thing I have yet to mention, and that is important, Syria before the conflict probably had a lot of tourists, and we had Iraqi refugees and others, but what's happening now is there is an increase in foreign forces and foreign fighters, and they might bring their TB incidents with them into Syria. I'm briefly going to mention the besieged areas. So everything I have said about Syria is 100-fold worse in these besieged areas, and at present there's at least 1 million people who are living under siege in unimaginable circumstances. And it's needless to say that any TB numbers I give you are probably just the tip of the iceberg, not just for TB but also for drug-resistant TB. So what is the way forward? I think the elephant in the room is the conflict must end, and I'd be amiss not to say that. There needs to be capacity building in terms of laboratory and healthcare workers, and Syrian healthcare workers are very keen to learn, and there are things that can be done now to train them up to be better microbiology technicians, but also for the diagnosis of TB in future. There needs to be improved surveillance, but also improved talking, and that's what I like about the Syria Public Health Network. I'm a clinician, I'm probably not someone that particularly wants to sit and talk with a politician, but more of that needs to be done. More talking with NGOs, academics and government actors, and also everyone focusing on the goal and putting aside their differences. There needs to be and can be more innovations. There needs to be more advocacy. So one thing that can be done for prisoners is to make it more public, because I don't think people know just how many prisoners there are inside Syria. And also perhaps international bodies, whether it's the ICRC, Physicians for Human Rights or others, can be allowed to visit those areas if there is nothing to hide. And actually screening programs could be set up, or any sort of healthcare could be set up for those prisoners. And we must all be aware of stigmatising refugees, not just in terms of saying TB, but also not referring to them as migrants. These are people who are fleeing war and disaster, and actually Syrian people were very proud of their country, they probably still are, and they would not have chosen to leave had their country not been destroyed. So the take-home messages are that the cases we see are simply the tip of the iceberg. There needs to be greater coordination amongst stakeholders. There needs to be greater support and training of healthcare workers, and that's across the board, not just for TB. Innovations are possible, and conflict, unfortunately, is a time of innovation, and perhaps now is the time to do it. And we need to think about now, but also post-conflict reconstruction. And so I'm going to move on. I've got 5 minutes to do Dr. Sahloul's slides. Lovely. So Dr. Zahir Sahloul is the former chair of SAM's Foundation, and he's currently the chair of SAM's Global Response. He's a pulmonologist from Chicago, and I would urge you to read a lot of what he says and also see some of his interviews. He was last in Aleppo in the summer, and he's well worth listening to. And as I've said, Valerie Amos always says that every time we use a new figure in relation to the Syria crisis, we say it's unprecedented. And I think we need to stop that. I think we need to make sure that the bombings against hospital and civilians can and should end. And I'm not sure this has come up very well, but the impact of the Syrian war is that there has been an influx of trauma cases, disability, psychological trauma, the destruction of the infrastructure, a shortage of medical supplies and human resources, and that has all led to a public health crisis, the rise of communicable diseases, and also an epidemics of infections. There have been attacks on healthcare and medical neutrality, and there have been unconventional weapon attacks, and all of this has destroyed the infrastructure and destroyed the health of the population. So I think Dr. Zahir was making a point with this slide to see just how complicated and actually how fluid who is in control of which areas are at any time. And from a public health perspective, I'm going to move on from this because it overlaps a little bit. I'm going to go on to a case. This is a very interesting case that will highlight some of the things that I've discussed. So this is a 23-year-old man who presented to the only pulmonologist in the city of Idlib. He'd been complaining of a cough productive of yellow sputum, weight loss, fever and night sweats. And can I just urge people to be careful with patient photographs, if that's all right. And the chest x-ray showed left pleural effusion and right upper lobe opacities. He had a smear that was AFP positive, and he was started on rifampicin and isoniazid. And the reason for that is ethambutol and pyrazinamide were not available. So he returned to the clinic after 4 months with a larger pleural effusion. He'd stopped taking his isoniazid and rifampicin for the preceding 2 months as he couldn't afford to buy them. The DOT programme that had been run by the Ministry of Health had been disrupted when Idlib fell to the rebels. He'd had multiple thoracocenteses done by the pulmonologist and was restarted on rifampicin and isoniazid. There were no sensitivities available for the reasons that I've discussed, and he continued to lose weight and complain of night sweats. And that's him. I'm afraid these slides hasn't projected because of the IT problems that we'd had earlier. What happened after that was that he was lost to follow-up, as many of our patients are. We don't know. He might have gone out as a refugee, either to Turkey or Jordan, or he might have died in the conflict. We really don't know. And also we don't know how many people he may have infected while he was on completely inadequate therapy. So what is the impact of conflict on TB? So the conflict has interrupted drug supplies and treatment for patients. It's increased disease transmission and drug resistance and relapse. The current prevalence of TB inside Syria is unknown. However, there's been a sharp increase in TB cases in neighbouring countries, and we're going to hear more about that from my co-presenters from the IOM. There are currently tens of thousands of people in prison across the country who are kept in conditions that are perfect for a perfect breeding ground for drug-resistant TB. And this is the last slide.
Could you wrap up with your case in Greece? I think that's more
interesting. Oh, yes, yeah. Okay.
Just speak off the cuff.
Okay. So I ended up changing the Greece case.
Okay.
I can give an anecdote about Greece.
You can contrast with the UK case?
Okay. I can give the anecdote about Greece. I haven't got the slides
okay.
up. So as far as SAM's global response, we're now working in northern Greece. And so we see on average 200 patients a day. We look after 4 refugee camps in the north, totaling about 3,500 patients. They're Syrian, Iraqi, and we have a large Yazidi population. The majority of the cases we see are primary healthcare cases, so respiratory tract infections, gastroenteritis, chest pain, cellulitis, mosquito bites. But we do see the occasional case for suspected TB, and actually we're linked in to Kilpno, which is the Greek version of the CDC. So one case that my colleagues saw about a month ago and they called me about was a young Syrian man in his 30s who had been started on TB in Syria and had taken about TB treatment in Syria, and I think he was about month 3 by then, and he presented to us saying, look, my TB treatment ran out a week ago, what do I do, can you help? So Greece has actually been fantastic in the efforts it's made to respond to this refugee crisis. They've had about 1 million people come in through their shores. However, the UNHCR and others have been very slow with the registration process. So many refugees spend months in the pre-registration phase. So with this chap, obviously, unlike coamoxiclav or amoxicillin, you can't just go in and buy it. And he was caught in this circle whereby it's a very clear-cut case. He's on rifampicin and isoniazid. He needs to be on that. But it's very hard for our doctors in Greece to obtain that for him, because for him to be seen in the health service, I think he needed to have a proper national insurance number, which he didn't have at that point. And so we kept escalating it up to our colleagues in the Ministry of Health, who are actually fantastic, and we did actually manage to get TB treatment for him. When you ask him more closely, it sounds like he'd had treatment interruptions along his course, because if you imagine if you're coming from Turkey, it can take about 2 months for you to reach Greece, and quite often the smugglers will take your belongings and just dump them in the sea. So you could really lose out on medication. So that could be a driver for drug resistance. So on that point I'll stop, because I think I've gone on.
Thank you very much, Olma.
Is it Alexandra and Safer?
Yeah. No, this is not the one. I want to show the programs.
Is it?
That's a holding slide.
I wanted this slide.
Yeah.
I mean the program slide.
Yeah.
Where is it?
In there.
This one is here.
Yeah.
How do I Do I have to do update? Do I click this?
There you
Okay,
go.
but I want the other one.
I think it was minimized.
Just
Was this full screen?
yeah, F5 full screen.
Okay. Our next presentation will be a joint presentation from Dr. Saiful Kayam and Dr. Alexander Galav. Dr. Alexander Galav is not feeling well, so he will not be here. Both of them work for the International Organization for Migration. Dr. Alexander Galav is the Regional Migration Health Assessment Coordinator for Africa and the Middle East. And Dr. Saiful is a physician and public health specialist. And he is working with the IOM with Syrian refugees currently in Jordan and Lebanon. For the past 16 years, Dr. Saiful has been working with humanitarian programs in Bangladesh, Sierra Leone, Sudan, Thailand, and Armenia with various organizations such as MSF, ICRC, and CARE. Yes.
So, as I said in the beginning, for the people that came late, we're holding questions till both the presentations are over, and we'll use the last 15 minutes or so for discussion. Dr. Saiful? Do you want to stand behind, or should she move the slides for you? What do you want to do?
I think I can.
Okay.
Same way. Yeah. It is in the presentation mode here. Okay. So then- Good morning, everybody. As mentioned, that my colleague and myself are supposed to share the presentation. So, because he's sick, he couldn't come, and I will try to cover the both presentation. Okay. This presentation will cover my previous colleagues talk about the TB and the healthcare inside Syria. So this presentation would be focused on TB impact, the Syrian refugees impacting the surrounding countries, particularly in Jordan, Lebanon, and to some extent to Iraq. So, outline of my presentation is, I will give you a little bit of overview about the emergency context and also the regional situation in Middle East in particular. I will skip there's few slides that's previous speaker already touched on, the TB control effect in Syria. So, and also then we will talk about the Syrian refugee influx affecting the neighboring countries, and the response on TB care, and the lesson learned we have, and the way forward. In terms of the overall burden of emergency in terms of the displacements, I mean, that globally 60 million people so far as a result of the emergency displaced, and it is the highest after the Second World War in terms of the total number of the displaced. If we look into the overall burden in this region, in the Middle East, Eastern Mediterranean region, at the moment 9 million refugees are in this region, so they are designated. And overall displacement, internally displaced, if you calculate for refugees and IDPs together, it is around 21 million in the Eastern Mediterranean region. And Syria is the highest refugee producing countries after Iraq. Okay, so at the moment. So this is a slide showing, it's from WHO, global burden of TB. If you look into the region we are talking here, is the Eastern Mediterranean region. It's third highest among the region per 100,000, is 122 per 100,000 population. Although it shows that its burden is high, but the region we are talking is in terms of the absolute number of the TB in the Middle East, but not high, because it is probably Pakistan and Afghanistan is part of this Eastern Mediterranean region that's really the high. And this is the regional scenario about the TB, although the number, the following slide will explain that the difference of incidence and prevalence in the countries in this region. This is the total burden of refugees in this region. This number is from the UNHCR regional database. These are the registered refugees in the countries surrounding Syria and Iraq. So there are more than 5 million registered refugees, Syrian refugees in these countries. So highest bulk of refugees in Turkey is more around 3 million, and Lebanon is over 1 million, and Jordan having some 700,000 Syrian registered refugees. But these are the number registered, but the estimated number, like in Jordan, that officially is around 656,000, but according to Jordanian government estimation, it's more than 1.2 million Syrians are living in Jordan. So those are undocumented, or they are with the host people not registered into the UNHCR register. And also there are some refugees in Egypt, is 117,000. But if we look into the distribution of incidence rate in terms of the TB, so it varies. Jordan is the lowest, 5.5 per 100,000, while the highest number of TB incidence in Iraq is 43 per 100,000. So it varies. So when the refugees come into these countries, it dilute the epidemiology of the region. I think I will skip this slide because the previous speaker spoke about that, as we learned that majority health facilities has been destroyed, that healthcare system is collapsed, and also in terms of TB care and management and monitoring and evaluation, it is almost impossible, and is all done, and we all rely on this and that. The same for, I will skip this one, that health infrastructure. I think that it has well touched by the previous speaker. I will just touch, this is the data we got from IOM and UNDP and Global Fund project there. It is from 2014. So reported number of TB cases is, as mentioned, I think that is close to what the figure I showed, that is 250 to 2,500 to 3,500 TB cases reported in 2014. But we do not know the precise number of 2015 onwards. So in 14 there were 31 MDR TB reported, and all were treated in Damascus. That's what, according to WHO and UNDP data. In particular, the Syrian TB, Syrian patient in Lebanon, that, as I mentioned, that is over 1 million Syrians in Lebanon, and they have also 450,000 Palestinian refugees. But these Syrians are not living in any particular refugee camps. These are kind of informal settlement they live. And NTP Lebanon is covering the TB care for like the Lebanese host people through 9 TB centers and 1 sanatorium. If you here it shows that magnitude of the number, that is a significant number of the Syrian total TB patient in Lebanon is Syrian. So there are other nationalities, but the second highest after Lebanese is the Syrian. In terms of the treatment success, it is 2014 data. I think that so relatively good. That comparing to the Lebanese is 89%, and the Syrians are 77% treatment success rate in the cohort of 2014. If you look into year-wise treatment, since the crisis started, Lebanese NTPs are following the Syrians. Altogether, from 2012 until now, that 480 Syrian refugee TB patients has been taken care of, and 71% were pulmonary and 29% extrapulmonary. If you look into the table here, that initially the national TB program coping with the caseload, that gradually year by year in terms of the success of treatment outcome and the treatment completed or cured. So initially in 2013 it was 63%, but gradually with the efforts of the international communities and national TB program, the success rates increased, and by 2015 it is now 87%. It's very close to the Lebanese population, so it's more or less the same. And also the same that in terms of the loss to follow-up, initially a lot of patients were lost from defaulted treatment, but gradually this number goes down, and now it's only 10%. For the management of MDR TB, thus far from January until now, so there are 6 MDR TB diagnosed, and it's a very small cohort, so 80% treatment success rate. All were MDR and 1 turned XDR and lost to follow-up, and currently 1 MDR patient on treatment. In Jordan, so around 700,000 refugees registered. As I said that, okay, so government estimate is 1.3 million. And also we have a significant number of Iraqis refugees, 550,000 refugees. So we have designated camps for refugees, 5 refugee camps, but only over 20% refugee live in cluster in the camp. But rest of the people live with the urban community all over the countries. And NTP with 12 TB center and 1 sanatorium covering the TB care, and yeah. So the service provision is equal, and the same for refugees and Jordanian people. And in terms of the total cases treated so far from 2012 until now is 255 confirmed case diagnosed among the Syrian refugees. And see that and among those 5 were MDR. In terms of the treatment's success rate, you see at the beginning it was a bit low, but number was small. Then it moved to above 90% and consistently maintained. So in some cases the result is even better than the host Jordanian TB patient. So this was possible because of the integrated approach of international communities, global fund support, and other international donors work together consistently. And that's how the good result has come. And in terms of the MDR, the number is small, is 5. So 2 cases cured and 2 died. It's 50% failure rate. And at the moment, 1 MDR cases on treatment. This is not Syrian. It's a Iraqi Kurdi XDR cases currently on treatment. So this is to show you that comparison that in terms of the Syrian case refugees comparing to the rest of the cohort in Jordan, that for Syrian it's around 95% on average for the cohort. So while you put comparing to the other rest of the country's TB patient, that is around 89%. So this is, as mentioned, that it is because of the international communities and donor support, and we manage, and also that too much patient-centered care, and also that there are some. So I will explain to you the strategy we took to get this good result out of it. So for Iraq, we don't have much epidemiological data, but the team they are working. So these are the information we collected from there. Because of the insecurity, we couldn't get the details of that. But more than it's only IDPs. Distribution of IDPs is only less than 15% reside in the camp, and rest of the IDPs with the host and in clusters, not in a designated camp. And it's still ongoing, the wave of displacements because of the ongoing conflict there. And many location is very unsafe for healthcare worker to provide service for the TB patient in terms of the case detection and the treatment follow-up. And there are certain pockets of high incidence, and in some area that's controlled by ISIL is absolutely unreachable. So we don't have much information on what is going on there. This is just to tell you in terms of the treatment management of the refugees patient in Jordan and Lebanon. The treatment regimen used is very standardized. That is, for the drug-sensitive cases, we use fixed dose combination and 2 month and 4 month and also category 1 and 2 treatment. That's very standard. And in terms of the MDR management, so it's also very standardized. So both countries have sanatorium inpatient for inpatient MDR treatment TB management. What we do that for the patient remain inpatient, refugee patient in sanatorium until culture conversion or during the intensive phase. And then in the continuation phase in Jordan, we do community-based DOPS. And for in some cases in Lebanon, the patient continue or whole of the treatment period inside sanatorium, and sometimes it's community-based DOPS. Okay. As WHO recommended for the short MDR TB regimen, we are also implementing. It is in the process of implementing 9-month short regimen for MDR. So for Jordan and Lebanon, we are bringing in moxi and clofazimine to introduce this one in the short treatment. And also in the laboratory, we are upgrading with line-proof for second line. And to mention here that in Jordan, before the conflict started, that the culture lab were only solid media. And also in Lebanon, there is another context that they don't have the national reference laboratories, but the culture and DST is through a private national lab, so they get the culture. In both countries, so to introduce a new, so as I mentioned that we have one Kurdish patient, is XDR, so we are, that patient tends us to getting towards introducing the new molecules that betaquilin and liramali we are bringing in, and also the others for a feed group drug, linezolid and amoxiclav and clofazimine. That would be first time introduced in the country for the refugees, and that would be also for the host TB patient. So challenges we have, as we mentioned, that because of the insecurity, so it's very difficult to do TB control area near the border, and also some undocumented refugees and IDP, their movement is restricted, so identification and treatment follow-up is challenging for them, and it's particularly in Lebanon. And in Jordan, there are some areas in the border, so people, refugees are stranded in between no man's land, and then Jordan government is not letting the health worker to get into these camps to take care of the diagnosis of the patient there. It's also complicated some refugees change the location because they live in urban communities. So in terms of active case findings and also the treatment follow-up, because of their movement, it makes it complicated. As I mentioned, that MDR TB care, while we started when we had the case, didn't have much laboratory capacities and also in terms of the clinical competencies. But over the years, we are upgrading the laboratories of national in Jordan and Lebanon, in Jordan. Then we have now access of liquid culture and first and second line DST, so we can treat MDR, even XDR cases in Jordan. There is also Jordan and Lebanon is middle income countries, so they are not eligible for the Global Fund grant, but we have got fundings from the Global Fund. That's the first of its kind, that an emergency grant that is for the Syrian refugees, not as such for the country as a country allocation. This is just to show you that impact of this crisis that over 2010 and 14, that if you look into two countries, Jordan and Lebanon, they have 25%, around 25% caseload increased in 4 or 5 years' time, while in Iraq and in Syria, the similar proportion of case decrease. So it come into the neighboring countries, just showing the burden of refugees. So in particular in Lebanon, that see the slide that over the year their Lebanese population detection was more or less stable and plateau, but in terms of the Syrian refugees, so it is on the rise. Okay, I have 2 more slides here. So we have several regional initiatives has been taken to address this issue. So as I mentioned, that Global Fund, first of its time, that come up with emergency grant through international organization supporting for the Syrian refugee, working in partnership with the National TB Program. So that is ongoing currently in 2015 and 16. And also in Jordan with Center for Disease Control Atlanta and in partnership with WHO and IOM and UNHCR, we have developed a strategy to address how to address the Syrian refugee TB care in Jordan. So that has been replicated over the year under the Global Fund grant, and also being followed in Lebanon. There are some cross-border initiatives that NTPs of Syria and Jordan and Lebanon, and also Iraq. So cross-border notification of the cases, that if the case is diagnosed here, to report back to Syria and vice versa. So this process is ongoing, and also we have come up with it's a guideline on, it's SOP, how to follow the cases cross-border. And also WHO has taken an initiative to develop a regional database of the conflict-affected countries, so that regionally the refugee cases can be followed through a single database, and also to ensure the surveillance of the cases. This is one example of some regional initiatives. This is an emergency. The WHO developed this guideline on TB care in emergency context in collaboration with IOM and ICRC. And the other one is this is a standard operating procedure we developed, which is particularly for Syria and Lebanon, that if the patient is on treatment and change the location, so how the treatment to be carried on, and also the notification and management. So this is developed under a Global Fund grant. So thus far, over the year of implementing the project for the Syrian refugees, our lesson is that is active case findings. That is important to combine the awareness and also the symptom screening, that we go for the to the refugees to identify the cases in the camp, urban areas, and hard to reach areas, and also active treatment follow-up and comorbidity management because of the mobilities. We used Gene Expert for the diagnosis and also mobile X-ray unit to track diagnose the case and also follow up. And then it is essential to have a complete agreement for coordination among the all partners, particularly with the national TB program and international communities. Last slide. NTP, of course, these two countries is strained with the caseload of Syrian, and in Jordan and Lebanon we have some funding gaps apart from the Global Fund emergency support. So because it's needed for strengthening of the healthcare system. So collaborative efforts with the international community and national TB program can produce a good result. As we saw, the good example is that in Jordan we managed to have a good treatment outcome that came under the partnership with the international communities and national program. And it is essential to have some innovative approach, like go for active case findings using the tools for mobile X-ray unit and Gene Expert we are using that produce so far good result. And to have a regional approach, and we need to address the issue of mobilities. And bottom line is that we need to strengthen the capacities of the national tuberculosis program for sustainable TB care for the host and the refugee community. We thank our partner, WHO, EMRO, NTP, Syria, Lebanon, and Iraq, UNHCR, UNDP, and Global Fund, and our colleagues in IOM.
Thank you very much. So, thanks to both the speakers, fantastic presentations, and especially in relevant, and when you consider the recent global TB report with the missing 3 million being no longer 3 million, 4 point something now, very depressing. Large proportion of that is made up of migrants. So I also want to announce that Dr. Galev is here, Alexander Galev. Thank you for coming in spite of being sick. So you may also take questions, right? Both of you can answer. Any questions from the audience? The floor is open to questions, yes?
I had a question. When you look at the first speaker highlight and the additional risk factors now for TB expanding in this population where it had gone down so nicely, as you saw. And I would like to know if you see now in this population that have are not checked for TB, do you see an increase in children as an indicator of recent transmission?
Or if you didn't hear the question, it was about the increase, how Syria was doing really well in terms of TB control, and now the increase. And are you seeing increase in childhood TB, which is an indicator of active transmission?
So the data we have is 12% of all the Syrians diagnosed in Jordan and Lebanon is pediatric. So we need to look into the pre-conflict statistics of Syria, then we can compare that whether it increased or not. So, yeah.
Hello? Any other questions, please? Did you have something to say?
We also got the directors of the national programs in Lebanon and in Jordan, so maybe they can also.
Oh, definitely, definitely. Turkey. Did you have something? Okay.
Yes, I want to give a small knowledge about Turkey. We have almost 3 million Syrian refugees.
Could you introduce yourself first? I don't think everybody.
Last year we have
Sorry.
almost.
Can you introduce yourself
Yeah,
first?
I'm
Okay.
Dr. Kılıç Aslan from Istanbul, Turkey. I work in university. Also, I represent of Anti-TB Association of Turkey. We have 3 million refugees, Syrian. Last year we have 400 TB patients in Turkey and 120 in Istanbul. Now there are 400,000 Syrian refugees in Istanbul. So there is last year we in Turkey government building refugees dispensary, refugees primary health care point, and NTB program is work together, and I think there are a few not registration patients is low, but TB treatment success is lower than Turkish total because the mobilization patients. Yeah, there are a few MDR TB, no MDR TB. There are a few in Syrian groups.
Okay. Yes.
طبعا thank you for Dr. Sifol for a good presentation, but I want to add the number as he said 1,200,000 because there is a lot of Syrian before the conflict was in Jordan, and about the number of the MDR, as he said there is 4 patient, 5 patient. 2 out of Jordan, 1 from Iraq and the second from Arabia Saudita. He is married from Jordanian, and there is 1 XDR. I want to thank IOM about the good cooperation. We go together to the factory, to the camps, and to other a lot of people, and for this cooperation we found a lot of cases of TB, and thank you.
Other questions, please? Yes.
Thank you, Dr. Seifel, for the good presentation. I think you covered almost everything. So what I want to say a couple of words, that when the conflict started, as you all know, we estimated as having 2 million refugees. 1.3 million are registered, but we estimate 2 million refugees in addition to 4.5 million Lebanese population. So the addition is 25% to our population. The situation in Lebanon is, let's say, not so stable. So we are very close to Syria. We are more or less engaged in this situation. As you know, we don't have residences 1 year, so that in this unstable situation, I think we did not bad to cope with this problem. So first, we introduce all refugees and Syrian TB patients in our NTB program. Second, we elaborate a new guideline and new strategic plan where TB and refugees is included as a part, and in migrant workers, of course, because we have a big population of migrant workers from high-burden countries. So what we do in our strategic plan, and we start to do some activities like active case finding. We did an informal settlement some activities, and it's ongoing process. I think we diagnosed more or less 30 to 40 cases in 6 months during this. But what the problem is, our brothers Syrian refugees are distributed in community. A small number of them are living in informal settlement, where the biggest is in the community. So we now start a pilot project for active case detection in this community with primary healthcare units selected recently with the support of our colleagues from IOM. And we pilot now this with a, let's say, symptom-based case finding in primary health care where the Syrian refugees are located closest to the border of Syria. And after that you will evaluate this and expand to all primary health care because of they are in our community. We cannot go door by door like in polio. It's TB, it's a stigma, it's not so easy to go door by door. Other thing is the problem of loss to follow. Since the biggest percent is in rented houses, so they are obliged from time to time to change their houses. We are doing now better because we have some experience in this. We were no experience, now we have some experience and we do, I think, better. What is it? So thank you for all support from IOM, from UNHCR, from WHO, and I don't know if there's any question. I'm ready to answer your question.
I
Was
would
that
ask Dr.
okay?
Riyam and Dr. Alexander, first of all, I think it is easy in Jordan because there is 5 camps. We know where where we we're going. But in Lebanon, there is an open border. I think a close relative, Dr. Riyam. أظن في الحدود اللبنانية مفتوحة أظني.
Not too much.
No, it's
Not
closed.
Not now. It used to be open.
So we always hear depressing news, but I think that on a positive note, the country programs are benefiting. You know, we heard about changes, program changes for active case finding, new drugs, new treatment, and new testing. So that's
And
more positive.
So we
That's
diagnose
testing, yeah.
now with gene expert rapid test
Right.
with smear
Yeah.
microscopy diagnosis.
And I think you
So-
mentioned the second line of
Yes,
essays.
yes.
Yeah. Okay. All right. Yes.
Thank you for the presentation. Just I'm asking about the community initiatives and volunteers. Are there any role of them in detection and follow-up
In
patients?
Syria?
In Syria and yeah.
Okay.
In the
Do you
whole.
want to take-
In Lebanon, I can answer something. We recruit, let's say, we have recruited community volunteers for this active case finding in camps.
Not counts.
Not camps.
In Jordan, we use the Syrian refugees. Even we use some TB patient for peer education, case detection, follow-up. So.
Can I just add to that, because I think that raises a really important point. For me, again, the elephant in the room is that they're very capable Syrian physicians and nurses who are not allowed to work in Lebanon or Jordan, and they will actually be deported back to Syria in Jordan if they're found to be working. And actually, I think Lebanon, Turkey and Jordan are doing such wonderful work, but it would really be, but they're clearly overburdened. But perhaps if even for limited registration for physicians, that is starting to happen, but we really need to push forward for that, because maybe Syrian physicians can treat Syrian patients, and actually Syrian patients do like to see Syrian physicians. They somehow just have more faith for some unknown reason. So perhaps that's something that we can push our Lebanese colleagues and our Turkish colleagues and our Jordanian colleagues to encourage, because yes, we can have volunteers, but remember, a Syrian would not have worked in employment for 6 years. And so, yes, they can volunteer, and actually a lot of the response is down to volunteers. And actually we have community volunteers in our projects in northern Greece, but actually we need to think about employment for these people, otherwise they will continue to take resources when Syrians are desperate to work. Yes, it is, which is what I think, I have to say, I am always so impressed by what Turkey is doing, and I think the best comment that I've read is, if you absolutely had to have a refugee camp, you do it like the Turkish people have done it.
Yeah, thank you. I would like to come back to the first presentation and now understanding that to some extent the systems work well in the neighboring countries in terms of like access to treatment and treatment outcomes. What does it mean to people? Is it more safe to them trying to leave the country to have TB treatment or to stay, or what's the options for the people?
So remember, inside Syria, it's people aren't thinking about TB as their priority, because the priority is the barrel bombs, the amputations, and the acute surgeries. And also, because remember, TB is not visible in the same way that an amputated leg or a missile that has flattened someone. So patients wouldn't go out of their way to seek TB treatment, and that's a public health risk in itself. The people inside Syria are struggling with all sorts of things. And remember, I mean, over 1 million are under siege, so even if they did have TB and they wanted to get treatment, it's just not a possibility. And many are afraid to go to checkpoints because it's very routine and you don't know which checkpoint belongs to who. And for instance, to get from, say, Damascus to through Derra to Jordan, that's a lot of checkpoints, and you don't know who's going to be stopping you, and you don't know which side they're going to be on or which side they think you're on. So I think that adds
people must really come in to let patients up.
I think, I mean, the government-controlled areas are one thing, and I think they have some sort of MTP, but I think more can be done to support NGOs such as SAMS, who are doing a very, very good job, and also people like UOSM, which is a collaboration of different Syrian expatriate NGOs who are making strides with diagnostics and trying to provide a health system in the non-government controlled areas. So perhaps strengthening and working with those groups is the way forward, not just with TB, but with everything else.
Yes, just maybe to complement what everybody said. Working in the past in Africa, I've seen it's a bit easier to mobilize people to work on issues like TB and HIV, because it's something that is very strongly present in the everyday life, in the community, in the work, in the neighborhood. But I really want to acknowledge the good work that has been done in the countries surrounding Syria, and I believe also in the Syria in areas where there are activities related to TB in this context. Because to take the context of Jordan, we have a lot of refugees, as Dr. Ibrahim pointed, which is coming from areas that is 3 times higher prevalence. And Jordan as a country has been reaching the elimination stage early. There is 500,000. And most of the TB cases, more than half, belong to migrant communities, migrant workers, refugees, and other mobile populations. So if this work has not been done, if the refugees have not been caught early, even on the border, with awareness raising, with giving initiatives, with showing where to report and how to report, with training the public health care system, how to refer the TB suspects, maybe we would have had a bit of different epidemic than what we see now. What we see now is really kind of a well-controlled situation, but if we don't control it well, it has chances or potential to escalate and maybe further ostracize or bring some negative feelings toward refugees or mobile or migrant populations. So I really want to commend the national programs in Iraq, Jordan, and Lebanon for really opening the door and welcoming everybody into the, let's say, the framework of the national TB program. And at the same time, the Global Fund for understanding the need to support, although those countries are not eligible. And at the same time, I really sympathize with the colleagues from Turkey, whereby you are doing the work by yourself. I really want to commend you for that. Anything that we can do to assist and to help, we are really open to that.
Thank you, Alexander. I think we're running out of time, but I want to especially thank the representatives from Turkey, Jordan, and Lebanon for being and contributing so much, being here, taking the time, contributing. so much to the symposium. I would request you to stay back. We'd like to talk to you a little bit more. The speakers, excellent presentations, but some of the things that keep coming up in my mind during the presentations are like, going from 23 per 100,000 to like, we don't even know the numbers now, and we can easily predict there's going to be resistance. We don't have testing facilities in Syria, we don't have drugs, true drug regimen, all the no-nos of TB management, and then the numbers that y'all are picking up in the host countries, how accurate is that? Forgive me for saying that, but we don't know, right? I think you would agree with me that maybe there's more. So, but I applaud you for starting things like active case finding, going out in the community, trying to find cases and find resistance. So thank you again, and Gillian will wrap it up.
Yeah. I think this was very relevant. I want to thank our speakers again, especially after Captain Floyd's presentation on the missing cases and now how we're seeing them increase. I think these presentations really hit the nail on the head with exemplifying why that's happening. And thank you all for coming.
Thank you very much, everyone.